want, perhaps not look after themselves. So let's see, the teenager was faced with type 1 diabetes. What impact do you feel that would have on them as an individual? Because we all know we've all been teenagers. Some of you might still be teenagers. What is adolescence all about? What was your experience of being a teenager? Were you all quite good teenagers? You were quite good? Okay. What about others? Amy, were you a good teenager? No? Okay.
Exploring, risk-taking, trying new things.
Yeah, for a lot of people, but not for everybody, yeah. And so most teenagers, the research shows that diabetes management is quite poor within adolescents because of they want to take risks, to be spontaneous, to be quite autonomous, and it's a huge transition that might occur at their stage in life. So having, let's just say, type 1 diabetes might lead to that sense of a loss of control. Prior to my diabetes, I was able to do whatever I wanted to. Now I have to monitor my sugar levels every day, and my fingers hurt having to do that 4 times a day, or I'm getting lumps in my stomach from injecting insulin, or I'm having to think more about what I'm eating. There might be that fear, loss of a sense of safety, particularly if you're having lots of low blood sugar levels, and it's ending up in hospital. So there might be that loss of freedom, not being able to do what you wanted to do because your perception of diabetes controls your life overall. And your constant focus on what my life used to be like before I had diabetes. Now obviously, not everybody is going to have these problems with diabetes because most people are able to manage their diabetes. But the people we see in psychology are the people who are struggling to manage their diabetes. It might have an impact on your level of independence because for teenagers you're having to depend a lot on your parents or healthcare professionals who are reminding you of the importance of managing your condition. It can have an impact on your sense of self. So a lot of teenagers have issues to do with their body image because some girls know that insulin contributes to weight gain, so they may skip the insulin in order to not gain weight. So that can be a problem. Or I've heard it before where teenagers say, I don't want to inject in front of other people because they might feel that I'm a drug user. And so having diabetes can have an impact on your sense of self and your identity. For some teenagers, it might also alter their plans for a career because for some jobs you cannot have diabetes and do that particular job because of the risk of hypoglycemic attacks. And the same issues might apply to adults overall. So let's have a look at the case of Donald. So this is Donald here, who is 17. And lecturing Donald unsuccessfully has been causing frustration for both his GP and Donald himself. Eventually his GP decides to refer Donald for psychological help to understand a little bit more about why Donald is so reluctant to manage his diabetes. Okay? So within the psychology session, the psychologist realizes that the problem started right at the onset of the peak of adolescence really at the age of 16. And at the time of his diagnosis, that seemed to coincide with a major transition. So for example, it being a really important year when he had to take exams, but also his parents had separated at the time. So we can actually see that for this particular case, it was really difficult for him at the time of diabetes. And all the research would suggest that support is important, particularly when you receive a diagnosis because you're in that sense of shock. And information and support is quite critical. So his thoughts were that, so in other words, the meaning for him of having diabetes is that having diabetes means that I'm ill and my body is weak. But people who have got diabetes are not ill, they just have a condition. If I think too much about diabetes, it will take over my life, so I better ignore it. I hate injecting insulin in public. People might think I'm a drug user, and my other thoughts are, why me? Okay? So that might lead him to feel quite anxious, fed up and low in mood because of his perceptions of his diabetes almost ruling his life. And his physical symptoms might be that he feels quite tired because he's not looking after himself very well and quite lethargic. And so because of all of that, because he's got very negative view of his diabetes, his behavior is that he doesn't take his insulin regularly and his sugar levels are very much erratic. Okay? So he's in and out of hospital several times. And he avoids thinking about his health. Now, prior to putting all this together, all we knew about Donald is that he's not managing his diabetes very well. But that doesn't mean anything psychologically, because we don't know the reasons why he isn't managing his diabetes. And so lecturing him is not likely to be helpful. So through further exploration, we realised that he's got very negative views with regards to his diabetes. So, approaches to making change. So after seeing the psychologist, Donald feels a bit better. He communicates his problems to his GP, who feels less frustrated and is able to express genuine empathy for Donald's difficulties. So this helps improve their relationship and encourages Donald to attend the diabetic clinic more regularly. Sounds quite straightforward, doesn't it? But in reality, you might have to go through several hoops before someone is likely to engage for most people. So Donald and his GP are able to openly discuss his fears and gradually move towards a much more balanced and helpful view of the situation, with thoughts such as, managing my diabetes better will prevent me from frequent hospital appointments, and I can be able to get on with my life despite having diabetes. So that's a positive outcome, but for a lot of patients, you don't get that turnaround straight away, because there are likely to be lots of other issues and barriers that stop us from trying to understand what makes it hard for some people. So psychological support has helped Donald to feel much more in control of his diabetes, and he's able to improve his mood. So that's a positive outcome, and that's what we aim to achieve. Okay, any questions about that? No? How are we doing for time, the chair? Okay, okay. I'll finish my section, and then I don't know whether, where's Lindford? Oh, you're there, okay. You want to present immediately after that. We have a break, and then you do your section. Okay. Our next well-stopped tour is looking at procedural anxiety, which is quite brief. So there is value, I think, in the role of psychology, particularly within medical settings. And I just want to say something brief about procedural anxiety. So there's a role for psychology within surgical services, because most of you that go for surgery, you might maybe feel a bit of anxiety, or maybe not. But some people generally find going for surgery quite frightening, quite anxiety-provoking, or going for a treatment where you're having to have lots of drips or injections. Now, you might not start off having a needle phobia, but over a period of time, you might develop an aversion to, pain, having your fingers pricked or having needles stuck into you all the time. For some individuals, going for surgery can lead to them feeling quite anxious about doing it, because it's that fear of unknown. Anesthesia can make people feel a bit out of control, and particularly if they don't understand the procedures that they're going into. So information is quite crucial. And there's a role for psychology in helping people to actually talk them through what might happen. So that would include, spending time with other professionals, explaining to doctors or the nurses what the issues are for a particular individual, to understand why is it that this person is having panic attacks every time they are going for surgery. In other types of surgery where people are going for reconstructive surgery, either for things like breast reduction, or they have a known disfigurement, there's a role for psychology there as well, because again, there's a fear of unknown if you're going for a change in terms of what you look like. And so we need to work with people to improve their self-esteem, or to make them feel much more in control of the decisions that they make. So psychological assessment is a key role, preparing people for surgery before they go for operations, helping them to ask the questions that they need to ask, rather than being anxious. I almost say, how can we put your anxiety into a question? What might you need to know to cope with this condition? So if you're anxious about, never waking up after you go for an operation, or that your operation is going to make your things worse, how might you put that into a question for your doctor or your nurse? And then you kind of get them to list down, I would like to know more about this surgery and how much scarring I might have afterwards. And the more information you get, you might see a reduction in their anxiety. Okay. So I'd just like to present to you a brief, what is called a formulation of a real case, someone who has struggled who needs an operation to remove a mole on her face. But each time she is prepared for anesthesia to go in for surgery, she has a panic attack, which means that she never gets the surgery done. So this is someone who has an anxious temperament, but generally has a negative view of herself and really doesn't really cope with change. So we know that as a factor that might make her quite vulnerable to panic attacks. So most psychological models of panic attacks explain that people normally have an internal or an external trigger that triggers off you feeling quite anxious. So in her case, her trigger is that the last time she had an operation, she didn't really cope very well with it. She didn't recover well. There was a lot of bleeding and she was at home for quite a long time. So memories of that operation and the effect of anesthesia, the fact that she just felt so surreal, is leading to her feeling quite anxious. And because of that, her thoughts are that everything is out of my control, I'm about to die, I might not survive this operation. So these are the thoughts that she's having at the time as she's nearing theatre. And of course, when we're anxious, we have physical symptoms, so we might have palpitations, sweating, feeling quite tense. So what does she do when she's anxious then? Well, she panics, and she refuses to go to theatre at the start of anaesthetic. Now, most people that have panic attacks often misinterpret their symptoms. So rather than telling herself you're feeling anxious, this lady's then misinterpreting her anxiety by saying, I'm about to die, I may not wake up. And that is keeping the cycle of panic going. So in terms of how you would work with someone like that is trying to understand what the cause of her anxiety is, working with her on these thoughts. So how can we manage your anxiety better so you can have the surgery that you need? And things like behavioural tasks, you might then walk her to surgery and talk her through to make the environment less threatening to her. And work with her to have some much more anxiety management techniques. Does that make sense? Okay. So, what do clinical psychologists actually do then in a physical health setting? Well, we know that psychologists assess, and we use a variety of methods to try and understand why someone is feeling distressed. So in order to do that, we use a clinical interview, which just involves asking questions to find out more about their presenting problems and to find out what makes someone vulnerable to having particular issues. So we don't just find out and say, well, someone is depressed, and we treat the depression. We try to understand what makes this person vulnerable to having depression. So if 4 of you were in a family and you had depression, my question would be, what makes you vulnerable to have depression and you don't have it? And I guess there's a curiosity that guides assessment. We do observations, we might use psychometrics to try and understand particular processes, and put together, that forms your assessment within a medical setting. We also do what is called formulation, which is, I guess, is in line with perhaps what people see as a diagnosis. And this is a skill that is, I guess, quite unique to clinical psychologists, but other professionals may also use formulation. So within physical health, I would be interested in what are someone's life experiences? Why are they vulnerable to not coping well with their diabetes or their chronic pain? What coping resources do they have? So has this person had a history of not coping very well? If they haven't, then we know that they're not going to cope well with any of these as well. If they've coped well with problems before in their life, that is a good strength to have, because it means that they'll be able to adjust much more better. What incidents or critical incidents have occurred, and what is the personal meaning of having any of these conditions? Okay, so for this person on the left, she has been diagnosed with type 1 diabetes. That has then triggered off thoughts such as, why me? I can't cope. And then she panics, and then she has more memories of her mum having diabetes and having her leg amputated because her mum didn't manage her diabetes. For this person here, they have the thought that I'm useless, I can't do the things I used to do because I have chronic pain, and so they become depressed, and as a result of that, they don't ask for help when they need it. So the cycle can continue. But formulation helps us to understand what is the personal meaning of all of this, and how can we understand this person's difficulties. Okay. In terms of treatment, it really depends on the presenting issues. So if someone's anxious, if they're not coping, if they're not adjusting to their operation or their medical conditions, etc., that will determine what talking therapy that we offer them. Yeah. Sometimes we might devise interventions alongside other professionals, so we might share that ownership in terms of helping someone to overcome their their conditions. And very much so in physical health, you're often not working in isolation. It's important that we draw on the skills of other professionals. So getting people like the nurses or the doctors or the physiotherapists on board with us, because people are likely to, these patients are likely to still have input with all those other professionals. Okay. So these are our objectives. This is what we hope to gain from having psychology in medical settings. So we hope to improve adherence to treatments. We hope to improve the likelihood of people sticking to their treatment and having a better quality of life. We hope to promote better coping behaviours. We hope that people are coping better with their conditions. We hope to improve their family function, because if somebody is distressed because of their physical health conditions, of course it's going to have an impact on their spouses or their family members. So we hope to then improve communication and better functioning within your family system. We also want to provide support for distress related to illness, so breaking down the stigma surrounding going to see a psychologist. Sometimes patients can be their own psychologist without having to make the step to see us. To evaluate and treat psychopathology, so things like depression or anxiety, that's what we hope to gain. But in some cases, medication might be needed for some individuals, and that is okay. And we might often refer them to psychiatry or to...
Welcome back, everyone. Good evening. Just to introduce myself, my name is Lynn. Please call me Lynn for short. And just to share a little bit with you about my current experience at this work setting, work placement that I'm now undergoing at NUH University Digestive Center, or specifically it's a bowel clinic that I'm attached to for this current period in my placement. Just to share with you a little bit about irritable bowel syndrome, IBS. Anyone in the audience familiar with this condition? A few nods and a few hands raised up. Okay, I'm not sure how commonly this disorder is in the current context, but this is one of the most current or most common functional bowel disorder we see at the bowel clinic at NUH. And some of the symptoms that patients present with would commonly be some of these symptoms I'm going to highlight will be abdominal pain or discomfort that they feel in terms of like tummy pain or sensation like as it is like prickly, and also intense pain sometimes. And they also experience bloating in their stomach. Basically, there's some distension of the stomach that they feel it's a bit bloated. Sometimes it's physically bloated, and sometimes it's an experience of it, or it's a perception it's actually bloated, but in actual fact it may not be as bloated as it seems. And the other symptom is constipation or diarrhea. It could be a fluctuation of either or from time to time. So some of the patients do experience this whole range of symptoms at one go as well. So IBS itself, it can actually express the symptoms in a couple of ways in terms of whether a patient seeks care, they adhere to the treatment, and it's largely influenced by some of the psychosocial factors that I'm going to explain a little bit in terms of the distress that they may experience, in terms of how it affects their mood, and it also can generate high life stress. And this is quite reciprocal in the sense that when they experience stress as part of their pain and their symptoms, and also translate to how they manage with other aspects of their life. And then again, if they can't cope with some of the stresses to do with the pain and work life and so on, then they exacerbate again the level of stress in their lives. And some of the patients, they may even stop working because it's very difficult to cope with this condition, because they have to run to the toilet very often, or they prefer to stay home because bearing with the pain outside or outdoors is very difficult for them, so they prefer to stop working. And I think quite a number of them, in terms of how it affects their relationship, is quite significant in terms of also partner burden, because for IBS patients, the pain is often it's invisible. Therefore, the partners can really understand the pain that they go through, which is very intense sometimes. So in terms of sometimes they receive complaints from their partners that was very painful, and experiencing a lot of bloating, a lot of pain to do with going to the toilet and back and forth, and they download some of these difficulties with their partners, and it's very difficult for the partners to also support them in some of this distress that they're going through. And some of these issues may affect also the commitment to their therapy and coping with the disease. So in terms of IBS, the patients that present at the clinic often may come with low mood, and it affects their sense of coping with their disorder, and it might affect their anxiety anxiety level as well, because they are unsure whether, okay, if I were to take the bus, am I going to have problems because I'm going to leak, or can I go to the toilet in time? And then they might, also have a sense of despair, whether can they cope with this condition if it persists for a long period of time. And coping with these symptoms often than not requires extra resources to deal with these two issues. Coupled with maybe when before this condition, they already had some other anxiety and depression issues, and having this new condition adds on further to having to cope with this new condition. So just to share a little bit about the research that currently I'm undertaking at Bowel Clinic, which is very fascinating and very interesting, just to share with you, what we are hoping to achieve in terms of understanding the profile of the patients that we see in this clinic. And want to understand in terms of how they view their quality of life, or the impact of IBS upon the quality of life, and understanding how they cope with the condition and how they understand what the meaning of they derive from this condition, and their adherence to medical care, whether they can cope or they can stay on the medication or the treatment that's been prescribed. And really it's very fascinating working with this population, because it's very interesting to see the brain and the gut connection and how it relates to their everyday life and how it affects them as a whole, as an individual. And also the statistics to understand what treatment can best help patients with IBS, whether it's psychotherapy or is it psychoeducation or a combination, or what else could be beneficial for these patients. So I think in terms of my role and part of the team in the physical health setting in this particular clinic, I find that it's really a great experience to be able to contribute to this area as part of the standard care and treatment that we provide for patients that we see at the Bowel Clinic. And I find that myself providing the holistic care for patients overall, not just in terms of the gastroenterologist providing the medication, also working with the nurses and also working with myself to deal with some other social, emotional factors that we can help them with. Right, that's a very short sharing. Unless anyone has questions to ask me, I hand over to Nenna.
Lynn has also just presented a bit about another physical health condition, because we've been on this whirlwind talk tonight, starting off with chronic pain, diabetes, and ending with irritable bowel syndrome. So I'd just like to work towards the ending of this and focus a bit more on psychoeducation. So how can you help yourself, or how can you help other people that might need help with their physical condition? So as psychologists, we take the view that if people know more about their condition, so they are educated in knowing why they have the condition in the first place, what is it that's causing them this